Right then. I'll hand over to Bronwyn Harris, who led this project, and we're so grateful to her and her team for coming to speak to us today about their DGN research. But first, we're going to start with a short video, a research-led video that they've produced for their project. So we'll play that now, and then we'll hand over to Bronwyn, who'll introduce the rest of the team. Oh, sorry, Ruth, it looks like that audio isn't working. Could you try again, please? In the meantime, I can tell you a bit about the project. So this is the project led by Bronwyn Harris, which is called Digital Health, the Digital Good in Low Resource Settings in Africa. And as part of that, they developed a series of vignettes to explore different healthcare scenarios in low resource settings in Africa. And the video is informed by their research and sets out a few examples of different ways in which people might use digital innovations for healthcare.
I'll try this now, Dee. Let me know.
Thank you.
Global policy is pushing us towards remote healthcare. But what does this mean for health systems in low resource settings? How does it impact access to healthcare? Is it practical? Is it always a good option? Remote healthcare involves two people connecting by phone around health issues. This is not as easy as it sounds. Throughout our research project, we have heard human stories about the dilemmas people face when using remote healthcare in low resource settings. Monde is the first in her village to go to university. She has developed anxiety and is accessing good remote mental health care. She doesn't discuss this with her family. When Monde returns home, her parents overhear a consultation. Her mom wants her to see the local nurse. Her dad suggests phoning a traditional healer. Monde fears neighbors will gossip if they see her attend the clinic. Juma is a nurse. He knows it is hard for patients to travel for in-person care during harvest and the rainy season. Juma is thinking about formalizing phone consultations at his clinic. Juma's team reminds him that some patient groups, especially women, do not own a phone. Older patients often struggle with digital literacy. The receptionist says the clinic provides a sense of community for people who attend in-person appointments. Iyanda is a public health specialist under pressure to introduce remote consulting to help shrinking budgets. She wants to make it sustainable. Iyanda works with both private and public frontline health services and mobile phone companies. She knows everyone needs to benefit for sustainability. She worries about patients' clinical data and their mobile phone use data. Is there capacity in the country to regulate data ownership and data privacy? There are no simple answers to these dilemmas. Solutions depend on local factors. By learning from human experiences in sub-Saharan Africa, you can help healthcare providers think and act in ways that will shape the use of remote consulting for good. Use our detailed research vignettes to explore digital healthcare dilemmas with your colleagues. Advocate for balanced discussion about the use of digital healthcare in your networks. To find out more about the research, visit bit.ly/digitalgoodhealth.
Great, thank you so much. So Bronwyn's going to start telling us a bit more about the project.
Great, thanks. I hope you can see my screen. Oops. Is that being shared?
Yep, that's working.
Excellent, great. Thank you so much, everyone. So we thought that we would just throw you into one of various endings to this project before we come back to the start. Given that this is a project focused on digital health, the digital good in low resource settings in sub-Saharan Africa, these were ethical dilemmas that evolved into the vignettes that you've just seen. And one of our reasons for starting at the end is that although it's an end, it feels like a very unfinished and ongoing discussion. And we're thrilled to be here today because we're hoping that we can continue to deliberate and talk about this project. I'm Bronwyn. I am a researcher at the Centre for Global Health at the University of Warwick, and I'm also the director of our online Masters in Public Health. My background is in critical psychology and public health, and I have a particular interest in finding ways to improve access to healthcare for underserved communities. So by way of context, we know that in much of sub-Saharan Africa, access to quality healthcare continues to remain a problem. There are multiple barriers which impede care delivery, and not only that, they reinforce health and social inequities. Also, the public health sector, which is the only form of healthcare for many communities, is heavily dependent on international donors and short-term election cycles in a number of countries. And in the last 18 months, there has been a devastating effect of the withdrawal of financial support across the continent. So these factors may influence how digital is perceived or used and how society defines and understands digital good. And these were the questions in our mind when we saw the first call that came out from the Digital Good Network. This presented to us an opportunity to develop our thinking as a team who has worked over the last almost decade on a very simple form of digital health, that of remote consulting, usually involving two people having access to a digital device, usually a mobile phone in this context, that's connected to consult about a perceived healthcare need. And in the course of the work that we've done, as well as a growing body of evidence about this, we know that remote consulting can help to reduce some of those care barriers, and when delivered by trained healthcare workers, can be safe and trustworthy. But we wanted to go beyond some of this to think about what it means to introduce digital health to society. The World Health Organization has the promotion of universal health coverage as a key policy goal. And the African Union and the states who sign up to that also support this goal within their policies. And we wanted to work on that cusp of improving access to healthcare and through digitization of health to explore issues which we've turned into dilemmas for not just health, but society. So briefly, we're defining an ethical dilemma as a decision that faces society about an ethical issue for which there's no one better or right choice. Effectively, any choice will bring some sort of compromise or conflict with an ethical principle. And here, those ethics are guided around the idea of aspiring to and enabling universal health coverage, with the idea that no one decision will enable this, there will be trade-offs. This was a very ambitious project. It was a team involving 30 people, drawn from a number of countries, Nigeria, Kenya, Tanzania, the UK, South Africa, Malawi, and Rwanda. And we worked very closely as a core team with our co-investigators, and I will introduce two of them in a minute, but also with the Consortium for Advanced Research Training in Africa, which is a set of 12 African partner universities and 8 non-African partner institutions, a consortium that's been running for 18 years that's dedicated to developing a vibrant African academy that leads world-class multidisciplinary research, particularly to impact positively on public and population health. So we were really thrilled to engage with a wide group of fellows and graduates who supported and contributed to our project, coming from a whole range of digital health research interests and backgrounds and a number of disciplinary perspectives. So at this point, I want to hand over to Archibong Bassi to introduce himself and to touch on one of the 3 methods that we used in our project. Over to you, Archibong.
Hi, everyone. Thank you, Bronwyn. So we used a couple of methods in this project. One of them was thematic analysis. As you can see here, we had secondary data sources, from different stakeholders. These stakeholders, included community members, included frontline healthcare workers, it included local and national decision makers, and also sadly health communication providers. So this was quite important because we had this data set drawn from about 10 countries. We had Nigeria, Tanzania, South Africa, Kenya, Uganda, even South Africa as well. So it was quite interesting, from a personal perspective to have this diverse stakeholder perspective. Now, thematic analysis, if we could go to the next slide, Bronwyn. Thank you. Now, thematic analysis, you would see here that our process was not just a straightforward, going to getting the data, then going to codes, and then going to themes. No, it was quite an iterative process rather than a linear one, because even at the point of getting, the themes, we thought we'd gotten the themes, we still had to go back again to the data set and then think of what could be or how these themes could become dilemmas. So there were at first challenges, which would show in in a minute to come. But then we then moved these challenges into dilemmas. So this was quite an iterative process. So we paid particular attention to the explicit dilemmas, which we found in areas of conflict, disagreement, or expressions of discomfort and avoidance. We also found implicit ethical dilemmas as well, which were drawn from our understanding of right-based and Ubuntu ethical concepts. Now, Ubuntuism, or should I say and right-based ethics, these were kind of the two approaches we used to get the implicit ethical dilemmas. For Ubuntu, it's more of a communitarianism approach whereby, the individuals themselves form part of the community. So it's like saying, you are because we are. So everybody is important. Then the right-based approach goes further, or should I say specializes in only the individual, recognizes the individual's freedoms, the individual's rights and responsibilities as well. But we discovered in the sub-Saharan African setting, which we got these data sources from, is actually intertwined. It's not something that, they chose the right-based approach or they chose the Ubuntu approach. So, we had these relationships play out between the traditional community leadership and also the frameworks that are available at the national level. Also, the individuals as well were able to interact with their communities, healthcare providers, and even healthcare systems, which we felt had implications for social good. I'll just highlight how my involvement in the Digital Good project has strengthened my capacity as an early career researcher on this project. So, firstly, from this, my understanding of the right-based concepts and Ubuntu ethics, I was able to move further to publish an article on why youth perspectives are essential for Ubuntu bioethics in the context of HIV testing. This was on BMJ Journals of Medical Ethics. And I was also selected for the highly competitive Global Health and Human Rights Fellowship, which aims to train fellows on, or should I say scholars on how global health, ethics, and even the human rights space works together. So it was quite interesting because I used my work from the Digital Good project as part of my application essay in order to get into the program. So, and now I'm selected. So thank you very much, Digital Good, and over to you, Bronwyn.
I think it's actually over to Clytie now. So I'm going to let Clytie Tian introduce herself and tell us about the second set of methods that we drew on.
Okay, hello everyone. My name is Clytie Tian. When I was working with Bronwyn on this project, I was a postdoc at Warwick, and now I changed jobs. I'm currently working as a lecturer in Global Business Communication at University of Aberdeen's Qatar campus. So I'm not currently based in the UK, but it's really nice to see all of you here today online. So for this second part of methods that we're using, it's more of like a thought experiment process. As you can roughly see, from the background of these slides, so we, as a team, developed a mind map because, as as we have introduced previously, our data set is rather big. And then doing the thematic analysis, we actually got a lot of different ideas around ethical dilemmas. So we thought it would be worth sort of play around the data a little bit more, and also this process will help us to get a better understanding of different ideas around ethical dilemmas. We had a couple of team members engaged in this process, so it's kind of a collaborative process, and also we did some cross-checking so that eventually the ideas we developed are sort of make sense across different team members. So this process, is coming from the data, and then we were sort of drawing out the key ethical dilemmas and ideas and the details from our data, and then trying to put them together in different categories, and also trying to see different ways that we could potentially group them. And also we had a lot of discussions about, different overlapping issues, when people are talking about ethical dilemmas, because it's a topic that will bring or kind of sparkle so many conversations and discussions. And this is a very helpful process, because we also eventually discuss a lot about whether or not this issue is an ethical dilemma, because sometimes people can talk about an ethical sort of related issue, but maybe it's an implementation challenge rather than really a dilemma. So it's a process that helped us to really kind of find a way for us to to give us a clear ideas of what we really want to bring out and how we define the concept of ethical dilemma. So how does this help me as an early career researcher? So in the beginning, of course, it really helped me to kind of enhance or strengthen my research profile. And it's really interesting doing something interdisciplinary, because my initial background was not really in healthcare, but in ethics. So it's really interesting to have a lot of interesting discussions with different team members, and which helped me greatly in my career. And now, I manage to supervise students, in this context related to remote consulting, because since I'm currently based in Qatar, and then this is where you get a lot of expatriates medical workers, and they also do a lot of remote consultings to clients, in different parts of the world. So it's a great experience. So I'm just gonna hand over to Bronwyn again.
Great, and thank you very much to both Archibong and Clytie. The third set of methods, which we were all involved in and which engaged the Carter Fellows too, was a set of deliberative workshops and storytelling that culminated in the vignettes that we started with. This was grounded in a realist approach, and we really deliberated over the course of these workshops and through emails and lots of WhatsApp chats whether, how, when, where, and for whom remote consulting might be considered good for society in sub-Saharan Africa. And we followed a process of generating a list of ethical dilemmas and ranking these, and then using storytelling to try and capture some of the key dilemmas and develop the animated vignettes in a way that tried to convey the human experience. So, there are two broad categories of results here, and in the interest of time, I'm not going to dwell on the first set because these are actually not the ethical dilemmas. But as Clytie was speaking, we as a team, and we see this in many of our engagements with stakeholders in remote consulting, encountered implementation challenges or a set of familiar and common worries that we realized we all needed to get through in order to kind of get past. So I'm just going to flash the slide up. It's something that we can talk about later or take forward in different ways. But these are well-known, familiar common worries that people tend to react to first. Well, if we go remote, what will this mean for quality of care? Will patients be safe? Will this impose on my workload? how will I draw professional boundaries? And we came to the conclusion that these are worries that can be mitigated, some directly and immediately in the short term. For example, we can offer training to healthcare workers in remote consulting in order to ensure quality of care delivered. We can continue to retain the face-to-face options available when introducing remote options so as not to disadvantage those who might not have access to digital. Patient records can be managed in the same way, especially as health systems try to develop and build their electronic record systems. And community education for improving digital literacy and negotiating the healthcare role is something that's quite achievable. Some of these take time, all of them need political will, but there is a right answer. It's not a dilemma, it just needs to have that time, will, and some resource to address. Of more relevance to the project focus and this discussion today, we surfaced the set of ethical dilemmas through those sets of methods that have been described. And you've seen some of these presented through the vignette. One set was revolved around whether introducing remote consulting supports or hides addressing stigma. So we know that remote consulting is often an important choice for people who are living with sensitive or stigmatized health conditions, who don't want to be waiting in queues, having society noticing that they're attending services for a particular issue. And this was one of the dilemmas facing Monde around her mental health. At the same time, if we remove this people from clinics as a space, what happens not just to the care that they're receiving in that interaction with their clinical provider, but to the social space that clinics offer. And this was a dilemma that Juma had to face in trying to decide whether to move away from encouraging people into their clinic and into remote consulting. That also links to questions about what a consultation means for patients, for the public, for healthcare providers. Do we want human touch? What is human touch? And is there an equivalent in digital warmth? And that, I guess, sets a set of future trajectories around AI, the use of recordings, digital twins, chatbots, a whole lot of additional, perhaps more complex forms of digital health. Challenges and dilemmas around whether or how to share data and privacy confronted both Monde and Ayanda as an overstretched public health advisor. And this was something which drew us quite directly into thinking through how Ubuntu and the kind of more individualized human rights approach, which tends to govern the health systems guidelines, policies, and formal practices, might come into conflict or could potentially support each other. If the community is valued with an individual being an essential part, but only part of the community, then perhaps privacy becomes less of an individually held concept. And so, who is involved in a consultation and how to control that when there's not a clinical boundary in physical space could present a key dilemma. And then finally, for today, Ayanda also faced the big challenge of how to regulate at a time when there's a lot of regulation and re-regulation and having to face new ways of regulating, and what this might mean for who is owning data, particularly given that digital health draws in so many new actors to health systems from private as well as public contexts, and big telecommunications, mobile phone companies, and the tariffs that they impose and the access that they may have to data was a key issue that led to us framing this as a dilemma. So, in conclusion, I suppose, which isn't really an end, but hopefully a beginning for a discussion here today, if we go back to the principles of universal health coverage, which is based on the idea of designing for all and leaving none behind, it appears through these dilemmas that even something that seems to be the most simple of digital health is not as simple. a new digital social solidarity, though, which perhaps uses Ubuntuism and its principles of valuing the community to promote a kind of social solidarity that also encompasses human rights and then allows those human rights principles to feed back into the communitarian social solidarity, seems to be, a way in which we could perhaps move forward in trying to tackle and address these dilemmas. And we wanted to kind of conclude with the point that we do need to tackle and address not only the technical and social challenges that come with this work, but the ethical issues that it raises, because without that, there is a very strong risk that the introduction of something as simple as remote consulting and by proxy a much broader range of digitalized health solutions actually aren't really sustainable solutions at all, because they may risk deepening inequities, undermining community resilience, and leaving most of us behind while putting a very few unfairly ahead. So, as I said, there were many who contributed to this project, and we are extremely grateful to the ESRC Digital Good Network. This has been one of the most delightful, engaging, fun projects. What Kaiti and Archibong didn't mention is that we met every week at times and every 2 weeks at other times for a number of months to run through these ideas. It was one of my best hours every 2 weeks to join the team. And we also extremely grateful to the additional funding that we got from Warwick University and the support from Carter that went into developing the vignettes, which were animated by Nifty Fox, whom we know is a good friend of the Digital Good Network. So with big thanks to everybody. Here are some references, and we're very much looking forward to the discussion now.
Great, thanks so much to you all for presenting about the project. That was really interesting. Can I remind any members of the audience that you can ask your questions through the Q&A function in the Zoom? And there is one question here. Can you tell us more about Ubuntu, its origins and core ideas? I wonder,
as who has built your career into a very recent publication, would you like to jump in on this?
Yeah, no worries. Can you hear me?
Yes.
Good. So, basically, I am because we are. So it's originated from South Africa. It's kind of a Zulu language. I'm not from South Africa, so I cannot. There's the phrase in South Africa. I don't know, maybe Bronwyn still remembers to speak most of it, but it's a Zulu phrase, which then translates into what we said, which is the I am because we are. So it's more of a communitarian approach. So like, I don't want to say it prioritizes the community, but it goes for respect, it goes for that solidarity Bronwyn talked about earlier. So trying to respect people in the community, trying to, that group network, that community. So that's what it goes for, rather than the individualistic freedoms or individualistic rights of individuals. So it's quite a, should I say, different approach to the right-based approach most of us in the Western societies are mostly used to and conversant with, using the frameworks of I think Bucham, if I pronounce that right, in public health ethics, which talks about all this autonomy, beneficence, justice, and non-maleficence. So that's a quite different thing from that. So that's what I could share. If you want to share something else, Bronwyn.
Thanks, Archibong. I mean, to add to that, this concept of valuing the community is not uniquely South African. It's very commonly shared across sub-Saharan Africa, and can be found, in other parts of the world too. There can be big challenges that come with this ethics, just as there are with a kind of human rights individualized approach. Our interest here was in how they mesh together, given that the health systems formally and the kind of democracies of the countries in which we were focused tend to use a human rights individualized lens, but on the ground, there's a kind of a practice that values and places the community and the individual in the community as part of tackling everyday healthcare delivery and social life. So, as a small example, in some of the transcripts that we analyzed that came from healthcare workers who we had asked, well, what would remote consulting mean for you? There was often a pressure for people who feel that in their role as a healthcare worker, there is an expectation that they are available to the community because the community's health is a priority, and that this can sometimes corrode or feed into a strong professional boundary, which a more individualized system values. So, people being called on at different times of the day and night to solve health-related situations. And we do know that there's a lot of informal remote consulting that's well entrenched within the contexts that we're talking about. And so one of the dilemmas that healthcare workers raise would be how to say no, how to sort of frame a professional status, given that there is a communal pressure to be a resource that is that of health, which wouldn't necessarily subscribe to those same professional personal boundaries. So, it's like that level of the intertwining and the outcome that comes with that, which was of particular interest to our team.
That's really interesting. Thank you. And I'm sure there's in the Digital Good Network, we have several sort of different approaches, perhaps more communitarian approaches that are drawn in, for example, Ubuntu ethics, Afrofuturism, and Indigenous perspectives, which, all help us think in different and new ways about a whole range of scenarios. And here it's digital healthcare. A question from Kim. Can I ask a bit more detail about the vignettes and how you decided to use these as part of your work?
Oh, thank you so much, Kim. I mean, what a great question, because it was so much fun and such a lot of work to try and think about these vignettes. So, oh gosh, sorry, am I still here? I seem to have pressed a button that took me away from being here. I think through the process of deliberation and given the volume of data that we analyzed, it became quite clear that everyone fell back into telling stories, actually, in trying to grapple with, well, is this a dilemma? It was either individualized to my own experience in my own life. And in our team, we had a number of, different roles representing healthcare. So, nurses, doctors, physiotherapists, occupational therapists, patients, community members, people who have managed health systems. So a range of stakeholders who in the deliberations were kind of interjecting with their own experience and ideas. And we realized that actually if we use storytelling to try and to create a narrative, this might help us to communicate these sort of quite complex theoretical ideas that we were all struggling to grapple with to an audience that we're hoping to reach with these vignettes. So, we're using them in our teaching. There's something that we've sent to stakeholders in our networks, very busy policymakers and decision makers who are looking at ways to take what is actually quite a low-hanging fruit. Remote consulting seems like quite an easy win. It's something that's fairly simple to set up in health systems, but we wanted there to be this complexification through the stories that were told. So the process, I'm not sure, Clytie, if you want to jump in on this, or Archibong, it was involved a lot of regular meetings to try and work out what the story was and how that storyline could be communicated in an accessible way. Clytie and Archibong, anything you'd like to add?
I think Clytie mentioned in the chats that she's going to be joining on the phone.
Oh, okay.
Yeah.
Okay.
Yeah. So for me, I think it was quite interesting because I've never really done a vignette in this format. I've done like writing scenarios, based on my charity sector experience. But doing this video vignettes really opened, I felt it opened more discussions because as Bronwyn said, we grappled with a lot of understanding how these things are dilemmas and how some are challenges, that could be fixed with some mitigation that we suggested. So all in all, it was quite fun and it was also a lot of work. So I really appreciate, the time we spent and seeing it come into fruition now.
I think it was also really nice to work with Nifty Fox because, this is a very creative process. And so that was partly why it was so fun. But, it forced us to challenge ourselves about visual representation. Who are these characters? What do we want them to say? How do we want them to sound? What do we want them to be wearing? There was a lot of detail that went into that, which really also challenged us to keep thinking about, how we're reflecting and focusing on this complexity in a part of the world where there's a very strong risk that it can, this kind of work can actually otherize rather than include. So, that was something which was a kind of an underlying parallel process for us all to go through and to just keep questioning the representation. And so but it was really fun to do that, I think. Thanks, Archibald.
I had a follow-up question to that. Well, two questions to that, actually. The first one is, have you sort of had any take up on the videos? Have people been watching them? What sort of discussions have they prompted? And for anyone who's joining, you can watch the videos on our website and we've posted the link. And the second question really is, do you think this idea of a dilemma is a helpful way to explore the digital good? Because so much of what we explore in the digital good network is about trade-offs. It's about different approaches for different people, things being specific and personalized. Do you think the dilemma is a helpful way of framing it?
Yes, I mean, maybe to answer the second question while reflecting on the first. So as an example, I use this in teaching in a module on global health, which is attended at Warwick by our Masters in Public Health students as well as humanitarian engineers. So it's a very multidisciplinary group, of people from around the world who are coming to study and think about global health related issues. And, playing the video and getting small groups just talking about what actually are the dilemmas here has been a very useful prompt, I think, for raising a number of these other challenges, which hopefully can, be taken forward into those different disciplines, as humanitarian engineers are kind of helping us to solve some of the humanitarian problems in the world, as well as public health practitioners, grappling with on the ground implications of digitizing health systems that are kind of digitizing around and beyond and despite a lot of those formal regulatory processes. So, I really loved your question about, is a dilemma approach helpful for, I guess, us visualizing what's good and how we get there and, what we might do as kind of that blueprinting process, which I know is your current focus in this final year. And I guess I think it is. At the same time, we don't want these things to be intractable to the point that we can't see the good. But I guess it's about encouraging us not to not be critical and to recognize that there are a lot of things that we need to grapple with as we strive towards universal health coverage, which remains a kind of an ideal and something that health systems and governing bodies are working towards. I mean, at the same time, not losing sight, though, of some of those technicalities and implementation challenges, because even although we've kind of glossed over them for the purposes of time in this presentation, and we know that there are mitigations and that there are right solutions, good solutions, rather than bad ones on addressing those. For example, one of the big challenges is actually probably less in solving the details of the consultation and more in ensuring that there's digital infrastructure to support the backbone of remote consulting and all digital health that happens. So, there are different interfaces with society where there are pockets for exploring good, and the dilemmas might get us to a certain point, but actually we wouldn't want to miss things that aren't dilemmas, but that actually, without putting them up front, we might try and solve in ways that create or lead towards the dilemmas rather than resolving the technical or implementation challenge that comes with that.
It's really interesting. Thank you. We have a question here from Helen Kennedy, the director, and she says, as the director of the Digital Good Network, I'm always amazed and humbled by how much great work the fund projects do with a very modest amount of money. Brilliant. So she says, here's a provocation. Is universal design / design for all, I can't remember exactly what term you used, actually a useful term given the complexities that you identified?
Brilliant question, Helen. Thank you so much. And I would love to hear your thoughts further about this provocative question. There is a lot of controversy around that catchphrase. I mean, I understand why it's there, and it does capture an aspiration. You know, designing for all and leaving no one behind is an important element of universal health coverage, because it's about ensuring that anyone, no matter who or where they are, has access to needed healthcare as and when they need it, regardless of their ability to pay. That is the kind of definition of universal health coverage, and it's one of the Sustainable Development Goals. So at least there's some kind of agreed currency on that as an idea. So at a pragmatic level, I think it's quite helpful, because it's something that's quite recognizable within health systems. You know, everyone kind of knows that's the slogan and that's what we're working towards. I guess in some ways we would, and I hope this did actually come through towards the very end, we wanted to be critical of that approach by presenting the dilemmas, because effectively, you know, number one, trying to design for all could just lead to designing for none, or to designing in ways that exclude those who most need it. So a kind of tailored approach that builds in context, that takes account of, you know, specific inequities and privileges, and prioritizes not leaving anyone behind, which is the second element of the slogan, would also be important. I guess at the same time, though, and this is where, again, our critique is hopefully coming through, it's not only leaving none behind, it's making sure that we're not pushing forward the very few unfairly, because, you know, given the world situation and the vast inequities that happen, there is that very real risk. That even within these slogans, that's what we're going to do. But that's why I guess we're advocating for a more thoughtful complexification of these things, which involves grappling with and hopefully addressing not just the technicalities, but the ethical and social issues that emerge around the universal health coverage case.
Thank you. Since our first round of funding, I guess global discussions about AI have continued at pace. And I was reading an interesting article about sort of AI regulation in sub-Saharan Africa, including Uganda, Kenya, and Malawi, are sort of leading the way in sort of innovative and creative ways of AI governance and regulation. I was wondering if you had any reflections on that in the years that have followed your project.
Archibong and Katie, anything you'd like to start with?
Oh, hi. For me, I think it's a lot, because it's like it was suddenly sprung on us overnight, the whole AI thing, and like we're just like, oh, what can we do about it? And governments in Africa do not want to leave their people behind. So even if they are not being the frontiers of it, I think the civil society is also pushing, as well as the people working in the digital spaces. So I think it's something we need to think about. But in the context of this work, we didn't really encounter much because the data was collected during around, I think, COVID or after COVID, during that period. I think 2019 to 2021 or something. I can't remember exactly, but Bronwyn has the details. So we didn't really encounter this then. So it's interesting to see how this, should I say, dilemmas that we originally had in, you know, the previous data sets are now reflecting broader issues in digital health today. Thank you.
Yes, and I mean, I see a lot of effort and energy going into thinking through what AI might mean, and the possibilities as well as the challenges, you know, that this might enable, particularly at a time, Sub-Saharan Africa has an extreme shortage of healthcare workers. Over 6 million healthcare workers short, if that makes sense. Not enough. 6 million too few. So the AI, I guess, has potential to support the services in several ways. At the same time, there are questions that the health workforce is asking about, well, what does this mean for my job? And will it, as many workforces around the world are questioning and asking, how is AI intersecting with employment, with labor, with what we're doing and how we're doing it. So I know that there are a number of questions that are being explored and examined under the health workforce kind of building block of the health system. And there are a number of, I suppose, social challenges that would be great if we could, find some funding to explore and take forward, that might help us, through this type of methodology, think about not just digital health in the most simple of forms, but the introduction of AI, what that has meant for society as well as for health systems, because I think it's the health systems that are still grappling with that. And how social spaces and social use of AI is also shaping healthcare use, and how people are using health systems, what they're expecting of health providers, what the kind of AI is telling them. There's some fantastic work that's happening around chatbots, and how this can reach and support people living with, again, stigmatized or sensitive conditions who might not trust the health system, but find some trust in a reliable chatbot. So a lot of different questions that we could be asking of this, not just for the health system, but for the society too. And I'm also very delighted to hear about the work that you're talking about, and I'll definitely have a look for that reference, because it's great to hear that there's innovation that's being led from the continent. And sorry, a final thought that takes me to another concept, which is that, increasing, I think in the world, these sort of simple digital processes like remote consulting have been heralded as a form of frugal innovation. I always think that we should replace frugal with the concept of good, actually, because, don't we want, to me, frugal sounds not as good as just digital good. But, there may be something there too about thinking through simple use of AI as well as these very complex processes which can help to solve, brain surgery and, cancer drugs, but also, how at a frugal level or a good level, AI does or doesn't shape society.
That's really interesting. And Archibong's also shared in the chat an article that he's written for The Lancet about Africa's digital transformation, which I'm sure people will be very interested to read. Okay then, well, I can't see any more questions in the Q&A. Let me just double check. So in which case, we may as well draw the webinar to a close. Thank you so much to Bronwyn, Archibong and Clytie for joining us today, for telling us some more about your project, and thank you everyone for joining us. We're having a brief pause in the Digital Good in Progress webinar series, but we'll be back and you'll be able to find more based on our newsletter, which is the link is in the chat. So thanks so much again to Bronwyn, Archibong and Clytie, and see you again soon. Thank you.
Thank you. Bye.